I have to speak about PEEP setting in COVID-19 ARDS. So I think that if this is the topic, it's normal to start from an idea of Luciano Gattinoni. Someone could say it's mandatory to start from this. You have already seen this. Gattinoni suggested two different phenotypes of COVID-19 pneumonia, type L and type H. These two patients have a very severe hypoxia. PF ratio is below 100 in both cases, but very different respiratory mechanics. Type L means low elastance, low lung weight. That means a small amount of not aerated lung tissue and low recruitability. Whereas type H means high elastance, high lung weight, and high recruitability. Because the reason for hypoxia in type L COVID-19 is probably to be located at the vascular side, it's quite clear that high PEEP level is not indicated, but in this patient we have to see the moderate to low level of PEEP. This is consistent with the fact that patients with a low potential for lung tissue recruitability also show a smaller amount of non-aerated lung tissue compared to patients with a high recruitability that positively respond to high level of PEEP. The Gattinoni concept and idea can be translated into clinical practice using this threshold in compliance. So Gattinoni suggested to consider an easy number to obtain at the bedside, the value of respiratory system compliance, to distinguish type L and type H. A compliance of 40 or higher, that means that our patient is type L. A compliance lower than 40 means that our patient is type H. And this is probably consistent with the way we compute compliance. Compliance is the ratio between the volume increase and the pressure increase in the alveoli, and is proportional to the number of patent alveoli that are ventilated. Okay, so the larger the amount of not aerated, of consolidated lung tissue, the lower the number of patent alveoli, the lower as well the value of compliance. This is the reason why the compliance of the respiratory system is very well correlated to the size of the baby lung in ARDS patients. That means to the residual inflated lung in this patient. So in the end, a pragmatic approach was suggested. Just look at the compliance of our patient and select PEEP accordingly. If compliance is almost normal or only slightly decreased, is higher than 40 ml per centimeter of water, select a low, medium level of PEEP, whereas if compliance is low, you are facing a type H COVID-19. In this case, we have to select higher PEEP because the patient is highly recruitable. Anyway, when this pragmatic approach was applied at the bedside, it came out that it is not that feasible. This is from Marcus Schulz's group in Amsterdam. They measured the amount of poorly aerated and non-aerated lung tissue with semi-quantitative CT scan and compliance as well. And then try to classify patient as H or L phenotype. And as you can see, they were able to classify as H or L phenotype only few patients that were patients in which compliance was low and the amount of poorly and not aerated lung tissue was 50% or more. And very, very few patients, just 2 patients, were classified as L phenotype, having a high compliance or normal compliance with 25% or less of poorly or not aerated lung tissue. But the very interesting result of this study is that it was not possible in the majority of the patients to classify into H or L phenotype. And this was particularly the case for several patients showing a high compliance, sometimes very high, with associated with a large lung involvement, with a large proportion of poorly and not aerated lung tissue. How is possible that such a patient with so severe lung involvement has a normal or even higher than normal compliance? The explanation is quite simple, and it's obvious that if you set a moderate low level of PEEP that is not able to stabilize the alveoli to avoid expiratory derecruitment, the tidal change in volume can be much higher than if you set an appropriate level of PEEP able to stabilize the alveoli and avoid expiratory derecruitment. So the message is that when we have tidal opening and closing, tidal recruitment, the alveolar snap opening is associated with larger changes of volume and higher compliance than a condition with a PEEP setting able to avoid expiratory derecruitment. These are 2 pressure volume curves obtained in the same patient, starting from ZEEP, zero end expiratory pressure in red, or starting from a PEEP of 10 centimeters of water. You see very different shape of these 2 curves. Starting from ZEEP, there is an S-shaped curve with a lower and an upper inflection point. that is associated with progressive recruitment of lung tissue that was de-recruited, going down to zero end expiratory pressure. If you start from a PEEP level that is able to avoid expiratory de-recruitment, the relationship between the volume and the pressure increase is completely different, is now linear. And what is really interesting is that if you compute compliance in the same pressure range between 10 and 30 centimeters of water, you see that the compliance value is much higher, is the slope of this relationship is much higher when you start from ZIP than when you select the optimal level of PEEP. So it's not that surprising that several patients with a diffuse loss of aeration in their lungs had a normal or even higher than normal compliance due to tidal recruitment. So probably we have to introduce a new subphenotype of COVID-19 disease that is what I call type U, where U stands for unstable lung. So in case of a diffuse disease, if you set a PEEP that is not able to avoid expiratory de-recruitment, you see tidal recruitment, and this is associated with a very, sometimes with a very high compliance. And probably we have to even more than 3 phenotypes in COVID-19 patients, because for instance, in type H with a large proportion of consolidated lung tissue, we observed both high and low recruiters. So this pragmatic approach that started easy and feasible is becoming more and more complex. So I think it's better to go back to a general rule that is in acute hypoxemic respiratory failure patient, PEEP should be set according to recruitability. In patients with low potential for lung tissue recruitability, we have, of course, to set low PEEP level, because otherwise we have just side effect of high airway pressure. That means an increase of alveolar stress and strain in the non-dependent part of the lung. Whereas in patients with high potential for lung recruitment, an increased level of PEEP is associated with a decrease of the non-aerated lung tissue, and more importantly, with a decrease of tidal recruitment. So a decrease in the difference between the amount of non-aerated lung tissue that we see at end inspiration compared to end expiration. And this is important because recruitability is not an opportunity for our patient, it's a risk, because we know that with the increase of recruitability, this is associated with a progressive increase of mortality in ARDS patients. And mortality seems to be more correlated with the opening and closing lung tissue than to alveolar strain, at least in the era of low tidal volume ventilation and plateau pressure limitation. This is probably the reason why it is in this subgroup of patients, those patients showing the highest recruitability, that setting a high PEEP level makes the difference in terms of survival. So my answer to the question is that in COVID-19 patients, we have to use the same rule as for, let's say, normal ARDS, that is setting PEEP according to recruitability. And of course, CT, quantitative CT, is the reference method to assess recruitability in ARDS patient, but a clinical approach, everyday clinical approach based on CT is clearly not feasible. We use lung ultrasound assessment at the bedside. This is a COVID-19 patient with almost all lung regions with normal lung aeration, lung tissue aeration, just some B lines in one posterior lung region. So if you like phenotyping COVID-19 patient, this is a type L patient. This is typically a PEEP non-responder patient. So we set low PEEP value in this patient, and we use inhaled nitric oxide as rescue treatment. This is a completely different scenario, looking at anterior, lateral, or posterior lung regions. Everywhere you see multiple coalescent B lines. This is severe, diffuse, inflammatory lung edema. Again, this is the unstable COVID-19 patient. Is usually highly recruitable, so we set high PEEP in this patient and we use promposition as rescue treatment. And this is the type H patient with almost normal ventral part of the lung and consolidated dependent lung regions. In this patient, we use by default promposition, and we set PEEP according to a, let's say, quantitative assessment of recruitability that we do at the bedside with this tool, the pressure volume curve, because you know that the hysteresis, that is the area enclosed between the inspiratory and the expiratory limb of the curve, is well correlated with the volume of recruited lung tissue. This was very recently validated against the reference method, that is the quantitative CT. Another tool you can use is electrical impedance tomography. I think it's a very interesting bedside tool to assess recruitability and select PEEP in ARDS patients. What you have not to do, in my opinion, is to use compliance to set PEEP. Compliance is a very important parameter to assess our patient and monitor disease evolution in our patient, but it's now clear that it's not the right way to set PEEP. It's now proven. So to conclude, PEEP in COVID-19 patients should be set according to recruitability, as in all the ARDS patients. In recruitable patients, we have to set high PEEP level, trying to keep positive value of expiratory transpulmonary pressure and avoid de-recruitment, whereas in non-recruitable patients, moderate low levels of PEEP are okay. Compliance, respiratory system compliance does not predict recruitability. There are several ways to assess recruitability in our patient. Use the technique you are confident with. And what is special to me in COVID-19 patient is this strange combination between high compliance and high recruitability that is not common in ARDS patients, whereas is very common, at least in my experience, in the very early phase of severe COVID-19 patient with diffuse severe inflammatory lung edema. Thank you for your attention.